to Pediatric Grand Rounds. I'm going to hand things off to Dr. Glenn Rosenbluth to introduce our speaker for today.
Great, thanks very much. I have the great pleasure of introducing Dr. Michael Pitt, who I first met when he gave a workshop on integrating magic into the physical exam back in 2013 at the PAS meeting. Dr. Pitt is an associate professor at the University of Minnesota, where he's also the fellowship director for hospital medicine, the associate director of the residency, and the associate chair for faculty development. And I think he's the first professional magician we've had give grand rounds. I think of him as really a Renaissance educator. He's really thought very creatively about frameworks for incentivizing scholarship and creating scholarship branding. That's something that I was fortunate to collaborate with him on some workshops and a paper. He's done a tremendous amount of work in thinking about simulation in global health, but also games for teaching on rounds, difficult conversations, and most recently Jargon. And I also want to highlight two recent articles, one on racial justice in academic pediatrics, a call for action and a plan to move forward, and then a second piece on achieving equity in global health that I think are both critically important. And I could probably spend another 10 minutes talking about Dr. Pitt's very productive career in medical education, and instead I'll let him transition to his talk telling us about diagnosing and treating the 7 types of jargon overuse. Dr. Pitt.
Appreciate it. Thanks so much. Nice to see you again. Hi, everybody. Hi to my friends from training, Mary Crawls out there, Carmen Cobb Walsh, who've done work with. Hi to those of you that are viewing that I already know, and I look forward to meeting the rest of you. This is something I get really excited about talking about, because we often hear people say there's the art of medicine and there's the science of medicine. Yet we spend our lives expanding the science. That's what the journals we read, we learn, we're getting CME for science, and we do very little to reflect on the art and ultimately what the science of that art is. Glenn mentioned this, but I grew up doing magic professionally and have both published on kind of what we bring to the bedside as clinicians, how we can leverage thinking like a magician at the bedside. But ultimately, it's caused me to reflect on the fact that the art of medicine is a performance art. And it's something that needs that honing of a skill. You know, if a surgeon is preparing for a retrocecal appendix, she may go, oh, this is a different approach than usual, and look it up in the anatomy textbook and game plan for that complicated procedure. Yet we enter predictably complicated conversations with families, informed consent, a nurse saying, oh, room 15 is really angry. And we just go, well, here I go. And we tend to not do the work on what science could be applied to that conversation. That's what I've started to get pretty excited about recently. I'm actually going to use this magic moment to illustrate a point as we talked about jargon. So I actually asked Charisse if she would turn her camera on for me and join me. Charisse, do you mind joining me? Perfect. Well, you're going to help me with a magic trick. I'm going to explain this magic trick immediately after we do it. So Charisse, this is an invisible deck of cards. I'm going to toss it through the camera. If you grab it for me. Okay, shuffle them up. You got to mix them up for me. Perfect. Take them out of the box first there. Great. Fan them out to yourself and take any card out that you'd like. Okay, look at it. Show it to the camera. I'm going to turn around. Now, they make different color invisible decks. Of course, this is red. Yours is blue. Put your card face up into that deck for me. Perfect. I'm going to throw it here so we have a real deck. And now I'd like you to just name the card you selected. What was the card you were thinking of?
Jack of Hearts.
Jack of Hearts. I want to show you something. Do you remember I told you to put your card face up? I also told you it was the only one from a different color deck of cards. Yours was blue and mine's red.
Wow.
Now, I promised you, thank you for doing that. I appreciate your help. I promised you I'd teach you how to do that. So if you got a deck of cards at home, you can try this tonight. This, of course, uses a version of the eight card brainwave effect, modified to an invisible deck routine using a full stacked chase deck and a rough smooth using a marks on the 7 to be able to reveal the selected card. Now that you know how to do that trick, you can pick up a deck of cards and do it, because I just explained it to you using perfect English. In fact, any magician would be able to know exactly what I said, and I revealed the magic trick. But if you cannot pick up a deck of cards right now and do that magic trick, you are non-compliant. That's the moment we're talking about. This sense that we think we've explained something clearly, and objectively, I've used magic jargon, and it's my assumption that maybe you know what that is. We do this with our patients all the time. We can be the smartest doctor in the world, and if our patients don't understand what we're saying, we are useless. That's the goal of this talk, how we'll reflect. And I think to a quote of Sir William Osler, that from the standpoint of medicine as the art for the prevention or cure of disease, the person who translates the hieroglyphics of science into the plain language of healing is certainly the most useful. That's what we're tasked with. How do we take gobbledygook medicine and make it digestible for families? A lot of us just say, don't use jargon. Unfortunately, we forget we're using jargon. We're terrible at identifying what we think patients know and they don't know. And that's been well studied, and I'll share some examples. The goal of today's session is to take time, not just in defining jargon, what is it, why do we use it, why it's a problem, but actually looking at a classification. In order for us to eliminate it from our diets, we need to be able to identify it. And so this will be looking at 7 categories from a published scheme we published, looking at 7 categories of jargon that we can eliminate. And then we'll actually getting into some practice mentally of what are some simple word swaps that we can rotate in and change to our vocabulary immediately to actually start having better communication with our patients. So we'll get started. As we think about this, I encourage you to take a second and just, if this were a test and you had to say what jargon was, just take a second to reflect on what your definition would be. So a dictionary definition is this technical terminology of a given group or idiom of a specific group. This is not just medicine. Think about what your partner may do at home if it's not medicine. If you've ever had to say, I don't know what that means. If you go to the mechanic and we are the one in the powerless position as the patient of our car being told about belts and fluids that need to be changed or are running low or are catastrophic. And we're the ones having to go, gosh, I guess I just have to trust them. I don't know what any of that means. It's a specific group. That example is going to highlight what it looks like to weaponize jargon. And I think we sometimes do that, and it's worth reflecting on. We'll talk about that in a bit. I like the second definition because it includes that word pretentious. It's often language that was used to kind of beef up our credentials. And again, we may just forget that others don't know it. Now we're going to think about why. So why? Easy answer, it's a shortcut. This is the least cynical. It's easier for me to say a precise amount of information in jargon conceptually than it is in plain English. I say conceptually because if the person doesn't know what I'm saying, and as a colleague or a consultant is too afraid to ask because it looks like they're exposing ignorance on a subject, then it's not a shortcut, it's a setup for error. But conceptually, it's a shortcut. I think a huge reason is that we are training medical students to look smart. And so how to look smart, how to fake it till we make it. And sometimes that's done because I know I'm supposed to say not that he has a tummy ache, right? And I'm not going to call a surgeon and say we've got Tommy has real owies, right? I need to have that precise language, and I learn how to play the game. And then sometimes it can be weaponized. I know when I have family members ask me about a medical question, if it's outside my expertise, I might fall into jargon to kind of hand wave that I know what I'm talking about and catch myself kind of using jargon as a weapon. And then the least cynical is just that we forget that there was a time we didn't know what those words meant. And I think this happens to all of us. We go, you didn't know febrile meant you don't have a fever? And you just forget that we didn't know that at one point. We didn't know that before our training. This is one of those moments. I hope that we will all reflect that this is our problem. This is not like when you're seeing a TED talk or a sermon and you go, gosh, I wish my sister was here to hear this. This message is for her. This is for us. We should be saying, my name is Mike Pitt. I overuse jargon. I confuse my patient. I can get better at this. And that's what we'll really dig into. So I actually have a West Coast documentary for you. So we're gonna zoom into a hospital in Seattle and take a look at 1 minute of a couple patient encounters and then come back.
I'll take 10. You take 10. Get in, get out. No smiling, no hugging, no letting them cry. Just be quick about it.
You're the one that's slow.
I am not slow. You are slow.
You want to bet?
Yeah, you are.
A comprehensive workup
Did not reveal any
vascular abnormalities.
Your Doppler was negative.
For deep venous thrombosis, so there's no need for chronic
Coagulation or an IBC
Your
filter.
biopsy was, however, positive
For a mixed anaerobic
non-group-based staphylococci infection.
Your BUN and creatinine elevations had us worried,
Rapidly progressive glomerulonephritis.
which could have signaled an autoimmune disease.
What does that mean?
We're not going to amputate your leg.
You get to keep your kidneys.
Congratulations. You can go home today.
Yeah, congratulations, whatever.
So it's funny, every time I watch that, when I first saw it, I thought, okay, this is over the top. This is ridiculous amount of jargon usage. And when I now pay attention to it, those sentences are said on rounds. Your comprehensive workup was negative. The Doppler was positive, et cetera. We were worried about acute, rapidly progressive glomerulonephritis. These types of things are said on a daily basis. Notice that it's not until they decode it with what it means for the patient, you get to keep your kidney, that all of a sudden it seems to be understood. So let's dig into what we mean when we say those categories so that we can work on removing these things. So we'll look at the first category. Your jaundice, which is due to elevated bilirubin, could be caused by cholecystitis. We're waiting for the radiologist to read the abdominal ultrasound to see if you may need a cholecystectomy. Again, probably feels like it's over the top, but as you reread that, that's something that could very easily be being said on rounds. This first category is what we tend to think about when we say the word avoid jargon. This is this medical terminology, words you obviously learned in medical school. Disease names, organisms, tests, procedures, drugs. Remembering that even specialties fall into this mix. In fact, in a survey of women in the waiting room of a cancer clinic, breast cancer clinic, less than half of those women knew what an oncologist was, and less than 1 in 4 knew what a radiologist was, people that were part of their treatment team. I know you mentioned your chair. I was talking to your chair earlier, who's a rheumatologist. This is certainly one of the fields that ask people to define, lay people to define, ask other physicians to define and give a nice, concise summary, and it's an area of struggle. So we sometimes are oblivious to how our own role, a hospitalist may not, which is what I am, may not be understood by the people we're talking to. So we don't spend too much time there because that's very obvious. We're talking about medical terminology, things you learn. It's worth just exploring that gets broken down often into acronyms and abbreviations. Your EKG was concerning for an MI, but before you go to the cath lab, we'll get a CBC and coags and make you NPO. So obviously, as we think, one part that could be confusing about an acronym is when it's actually said out loud, we say, oh, we thought you might have an MI, that's a myocardial infarction. That hasn't helped anybody, right? So just saying it out or expanding it out, even complete blood count, doesn't necessarily help decode things for families. So that's one problem. One is that certainly they sometimes don't mean, there are multiple meanings. So ASD, for years, I only knew of as atrial septal defect and saw many notes where ASD was supposed to be telling me as the reader that this patient had autism spectrum disorder. And I did not know that acronym, and for years did not pick up that that's what was being told to me for patients as an attending. So again, this can happen to us within our fields. I think acronyms that sound like a word, cabbage. There have been many examples of patients saying, I don't like cabbage. Why do I need cabbage? When it's being said that, or kind of sounding cute for something that's kind of scary for families. And so being thoughtful about actually when we're using acronyms there. Other times the letters couldn't help you if you wanted them to. So EKG, the K is for the German cardiogram. NPO, Latin for nil paras. What you'll find people say on the wards is they'll say, we need to make you NPO. And then they'll say what that means in Latin, which means nothing by mouth. That has been shown to not be understood by families. And if you think about it, that's a pretty weird way to tell somebody not to eat or drink. None of us say like, oh, getting to be lunchtime, what am I going to do by mouth? Right? That's not the frame we use to talk about eating or drinking. And then it's when it's been studied in health literacy studies, if your doctor told you nothing by mouth after midnight, what did that mean? there's a significant portion of the population that thinks they're still allowed to eat or drink after midnight. So being clear, it takes a lot. It's just, might as well be right the first time and say, we need you to not eat or drink anything, even your medication, etc. And here's why. And then we think about the emergency department. This is a relatively recent acronym that mirrors kind of the movement of, we're not just a room, we're a department. And so we shouldn't be just the ER. Yet patients don't know that frame and haven't been along for that journey, nor have television show names. And so when we say to families, have you been to the ED or did you go to the ED, which is what we've been trained to do, that's not the acronym that they're using. If anything, they may know ED from a commercial for Viagra. So we can cause even more confusion worth thinking about. So category 1, obvious medical terminology, things we learned in medical school. Category 2, acronyms of that terminology. Category 3 this is this familiar but not known. Medical vernacular, things that have been heard and maybe in TV show kind of parlance, but not landing to the point of families being able to actually define them when being studied. Things like febrile, cultures, electrolytes, body parts, spleen, scapula, things that have been heard, but that's a very big leap of an assumption to mean are understood. And again, has been studied again in this cancer population, remission being the goal of cancer, being overwhelmingly not understood or able to be defined by cancer patients of what remission means. So being thoughtful that even our terms that we think might be this kind of celebratory moment aren't landing with our patients. I think this category is the first one that gets really easy to just think, gosh, we really could stop using any of these. These are unnecessary synonyms, words that everyone has a shared definition of what the word is, and we just complicate it with jargon. So upper extremities become arms. Erythematous becomes red. There's no difference between the word red and erythema. There's zero difference except 11 letters, multiple syllables, and the opportunity to confuse. I've had patients say, are they ambulating? No, as they walk across the room, as the patient walks around the room. Think about the overlap here where acronyms can do this, can serve as an unnecessary synonym. When you look at an optho note, and OD for right eye and OS for left eye, which is confusing because OS is also a word in medicine, which is another jargon word, and OU for both eyes. That is a setup for error. Just tell me the right eye, and we could eliminate this from all of us in our training. It's not necessary. Again, oral intake for eating and drinking. So these are those words that if you find yourself defining it with a word that everybody understands and means exactly the same thing, that's an audit check to get these words out of your vocabulary. Again, it's been one study looked at patients in an orthopedics waiting room, asked them if there was a difference between a fracture and a break, and if so, if they answered yes, which one was worse. And the majority thought there was a difference. There's not, with 3/4 thinking a fracture was better than a break. I've had both these sentences said by patients on the same day when working in an emergency department. Oh, thank God it's fractured. I was worried it was broken. And oh, thank God it's broken. I was worried it was fractured. So recognizing that we certainly create some of this confusion. As an English major and a Twain fan, I never write Metropolis for 7 cents because I can get the same price for city. This is that kind of calling out that sometimes the pretension of our language may in fact be causing some confusion. So category 1, obvious medical terminology. Category 2, acronyms of that terminology. Category 3, medical vernacular, things that are familiar but not known or understood. Category 4, unnecessary synonyms. And now we're into category 5. I don't appreciate any focal tenderness in your abdomen, and the CT scan was negative. These are words that called medicalized English. So words in which there is a clear understood definition in English. Medicine has hijacked the word and given it a new meaning that's often the opposite of the way it's an accidental antonym. So if we think about, the word occult, if you actually think about how every person in the world besides medicine uses the word occult, and we now say we're looking for an occult infection or occult bleeding, that is terrifying to families. A demonically possessed source of blood in your child. And we just kind of throw this to mean hidden. That is not the way the word is used. An occult fracture, an occult bleed, occult, etc. Appreciate. I kind of learned of this category when my wife was showing me pictures of a family vacation. And she said, geez, my mom's gained weight. And I looked at the picture and I said, appreciate the way we tend to say it in medicine. I don't see or hear something, but somebody else might. I don't appreciate a murmur, but the cardiologist might. That's not the way it's used in English. So she said, I think my mom's gained weight. I said, geez, I don't appreciate that. She goes, what do you mean you don't appreciate it? What do you care? I said, I just don't appreciate that she's gained weight when I looked at the picture. I don't understand why it matters. They were on a cruise. It was Mexico, and it made me realize that she was hearing, I am offended by the fact that I don't appreciate that you said that, versus the way we use it in medicine. Something being impressive, a chest x-ray being impressive means something very different than your child's grades on their report card being impressive. Yet we say this to families. In fact, a family once asked me to look at a diaper rash of a patient. And I said, you know what? It's not that impressive. And the dad goes, his penis? I said, oh my gosh, thank you for clarifying that. No, and I realized and talked to him about how that was jargon. And I hadn't realized that was a jargon term. Focal. Just this week on service, a patient, the team said, we haven't started the patient on a diet yet. We all knew that meant they've not put the order in the computer to allow them to order whatever they want from the cafeteria. The family heard, we have not yet made the decision to pull the trigger that your obese child needs to be on a diet. That's the way the word diet is used in any other context. Really worth reflecting on the way our words land when they have these different meanings, often in a judgmental way, and we'll talk about that in another category. I gave this talk a couple years ago, and somebody said, yeah, I had a CAT scan when I was in high school, and the report said the testes were unremarkable. And he goes, it was not until med school, like 7 years later, that I went, oh, they just meant normal. Like my whole life, I was like, what does that mean? What does it mean I have unremarkable testes? So just kind of realizing, especially in the open notes, my chart era, that our language lands in real time. The paper we published on this 7 categories had a really nice letter to the editor response in JGIM. And it said, we're specifically confusing things in open notes, like we're moving the patient to the floor, being a very confusing thing for a family to read about their child getting taken out of a crib and placed on the ground, So it's worth reflecting how this lands. A study in Britain asked families, if you were told the tumor is progressing, is that good news or bad news? 48% thought it was good news because progress is good. Any other context we use that language, that tends to be progressing nicely is what's understood. Yet in medicine, a tumor progressing is, of course, bad news and actually deflating, yet we might not realize that that's what our patients are not hearing when we communicate it. No word causes more confusion besides negative or positive. I actually think COVID maybe has helped us with people understanding positive and negative a little better. But if you think about it, in the real world, positive is a good thing. Be positive. I got positive feedback, positive outlook on life. Negative test result, feedback at work, negative reviews on Yelp for that restaurant. We shouldn't go there, but we go to medicine. Positive is bad. Your lymph nodes are positive. The MRI was positive. That's bad news. Negative is good. The test results were negative. That's good, but it doesn't mean negative the way you've known it to be your whole life. I'm going to share a strategy to how to eliminate these words from your vocabulary when we get into the swap section. So I think the 6th category is where we actually know we are using a new word. We are intentionally substituting something in under the conceptual goal of softening the blow of something, or maybe feeling more less crude. So we might not, the beauty of being a pediatrician is we get to say pee and poop. We shouldn't be asking kids if they've had micturition or voided. I remember my sister, as a pediatric patient once, was asked if she'd moved her kidneys by the nurse. And we honestly were like checking to see if she'd in fact moved them, not knowing she was asking if she'd peed. Those of you that work in patients with end of life know how difficult it is to use the word dying, dead, patient died. It's very hard to say those words. So we tend to use euphemisms that don't land for families and can cause even more confusion. So it's been well established in those moments. For those of you that work in ICU settings or encounter this more often, that word is important to hear. Studies have shown that euphemisms for things on X-ray imaging cause more anxiety for patients than actually spelling out what it is that's being seen. So hearing out a spot on my liver caused anxiety for years in these patients, as opposed to having it explained. And then I think one that I think of a lot, we tend to euphemize infectious organisms as bugs. That's a word that has a meaning. It's medicalized English. It means insects to people. And so I've had many people, when we're talking about bugs in the urine or bugs in the ear, hear that there is an insect in their urine or an insect in their ear. And only on the follow-up questions do I kind of have that jargon exposed in my conversation. And then I hinted at this a little bit earlier, but a full category I think is worth highlighting is this judgmental jargon. These are terms that intend, just the way we're trained, do not intend to sound judgmental, but especially in the open notes era, as you hear things, you go, gosh, that's a little obnoxious to say non-compliant. We talked about you were non-compliant if you couldn't do the magic trick I taught you at the beginning. Yet we all know that was not your fault. That was my fault. So we should maybe think about how to phrase that. It's been studied that the phrase, we don't say denies cancer. We say denies alcohol use, denies sexual activity. And it's an implied judgment that we don't believe them. And this has been captured, whereas we can say patient is not sexually active. And of course, the reader can know we didn't hire a private investigator, that there's a possibility that's not true. But denies captures a judgment, especially in the open notes era, and has been a trigger for patients to change providers because they said, my doctor kept saying I denied alcohol use. I've been sober for 20 years, and so I was sick of seeing them. So we went somewhere else. Even chief complaint is kind of obnoxious, right? What are you complaining of today? What do you got now? What's your complaint today? That's how it could land to patients, though it's obviously not the way we intend it. Failure is a loaded term. Failed, can't contribute. Failure to thrive is a billable diagnosis. As a parent of a child who took about 3.5 weeks to regain birth weight, that failure stung as we were trying everything we could. And so just realize, I say to families, hey, I'm going to tell you the term used for this because you may hear it, and I want you to know why it's said. This is meaning that we're not seeing the weight gain we expect. It does not mean that you're failing. I just want you to know that I hate this term. I'll take the time to spend that. And then there's kind of initiatory jargon. These are just like the words we learn along the way to be kind of part of the club. But if we actually had to explain them out loud, are pretty, offensive. Gomer, get out of my ER. A rock for a patient that's not leaving the floor. FOS on an X-ray for full of stool. FLK in kind of a syndromic facies. I still hear this. If I ever had to explain that to a family, that would be pretty horrific. And so really reflecting on some of the stuff that deserves to be out of our vocabularies. I will make sure that you have a copy of this article that spells out these 7 categories with examples. The pocket card on the right is from a paper that will be coming out in a few months where we actually audited in real time jargon usage on the floor. So we had observed rounding where we timed the rounds and captured how much jargon, and especially that was not explained. Obviously, if you immediately explain the term, it's no longer jargon, and kind of categorize that into the different categories, showing that they were all represented during those observations, with those first 3 categories being the most commonly referenced. So we all do this. That 4 times per encounter actually was mirrored by an outpatient study that was done of recorded patient encounters. And so shows that this is a problem both in the inpatient and outpatient study. There have been standardized patient encounters that have documented as many as 70 jargon usages per 10-minute encounter. And so recognizing this is kind of an endemic problem. So we've talked about what jargon is. We've started to dissect what it is specifically so we can systematically remove it from our vocabulary. And now we'll take a look at some actual swaps in language that we can do. So the first point I want to highlight, it's not to never use the medical term. And I've swung the pendulum too far sometimes and discharged a patient with meningitis. And when they saw the discharge paperwork, they go, wait, I had meningitis. And so we absolutely need to be empowering them with the terminology they need to know. It's just not making the assumption that those words are understood. I think of this all the time. Our role, regardless of what we do when we're in a room, if this is outpatient, inpatient, when we leave the room, the family picks up the phone and they call somebody and they say, or they text and they say, the doctors were just here. Here's what they think is going on. Our job should be to make that conversation make sense. We should role play that out with them, get them prepared for that conversation. So I think of my job on rounds is so that they can call their friends and family and not say the same sentence that every patient could say. Doctors are here. They still don't really know what's going on. They're running some tests. They don't think we get to go home today. That's the conversation for the majority of families. They should be able to say, the doctors were here. They thought it was pneumonia, but the x-ray actually made them think it was something called bronchiolitis, which is this. Really empowering them to have a meaningful conversation with them. And I will use this as my teach back. So instead of saying, what did I just tell you? Which is a best practice and is shown to lead to retention of knowledge, but I find patronizing. I say, we've talked about a lot, and we don't often do a great job explaining it is what we're doing. I'd love to hear you summarize how you'll tell this to dad on the phone so I can clarify any areas where I wasn't clear and fill those in. I know you came up from the emergency department and they talked about croup down there. I like to just hear your summary of what it is that means, and I can fill in any areas where we haven't been clear in explaining it. I make it my fault if they get it wrong, and it's not a quiz, it's an opportunity to learn, and it's an opportunity for feedback for me, because many times I go, oh, geez, that was not what I was trying to say. But if I don't ask that question, I'm not getting that information. And I coach my family and friends to not leave the doctor's office until they say the sentence, okay, here's what I'm going to tell my husband when I get home. Here's how I'm going to summarize this to my wife. Make sure that they do that. And often in doing that, they identify gaps in their understanding and hopefully are using that to capture feedback for the providers. For those of us that do inpatient academic medicine, we think about what it looks like to round. And so often we say we're doing family-centered rounds, but we're doing family-present rounds. The family is eavesdropping on a conversation that we are having as doctors. I would much rather eavesdrop on a conversation that the resident was having with the patient, and I can translate it into medical speak and cut out the middleman. So instead of them saying to me, Jack was afebrile overnight and his rash is no longer erythematous, tender, or desquamating, they just say to Jack, hey, I saw you didn't have a fever overnight and your rash isn't red or peel anymore. That's great news. I can translate that into medical speak using my degree. I don't need to make the family wait while we do both. Cut out the middleman. And I'll say family-centered rounds can be done very effectively, jargonless, in a SOAP format. SOAP, what is it you want to talk about? What is it you want to make sure we cover before we leave? Rather than subjective, no overnight events. And the family's like, are you kidding me? Last night was the worst night of my life. And we've just told them that they had no overnight events. I've been the patient in that situation and it's miserable. Objective. So what does he want to talk about? Objective. Here's what we know since I saw you last. We got this study which showed this. We did this test which showed this. Assessment. Here's what I think is going on. Here's what we think is going on today. So often our learners go right to the plan, or we teach them to restate a history as an assessment. A 5-year-old male with 3 days of cough and runny nose is not an assessment. That's a history. An assessment is Tommy has pneumonia and I think he's getting better. And so really some of this is us undoing the way we've been taught so that we can make those phone calls make sense. And then going through a plan in either your kind of systems or problem-based format, but that can all be done jargonless with the family at the bedside and me doing the interpretation rather than the other way around. So let's look at some swaps. I want you to think about these. The blood cultures were negative. We talked about how this word means something different. And I mentioned that I would give you a way to eliminate the word negative from your vocabulary or positive in medicine. The two strategies I use here, show your emotion. A really helpful way, people are way more likely to remember the way you felt about something, the emotion behind how you shared it, than the actual words. So if I can say something made me happy, or I was thrilled to see, or I was disappointed to see, that helps them say, yeah, the doctor was a little disappointed to see that it was still there. That's a lot more helpful than the potassium was 5.9. Like it's giving them the emotion behind how I feel around it. And then the way I've learned to strike negative or positive is to use the patient's name as the object of the sentence. And I'll show you what I mean. It's like a Mad Lib. The test showed me that the patient does or does not have X, which I was emotioned to see. So as you see this with the test, the blood cultures were negative. The blood work showed me that Sarah does not have an infection, which I was happy to see. The cat, again, I can't say the CAT scan, I can't say Robert CAT scan, or the CAT scan showed me that Robert was negative, right? But the CAT scan showed me that Robert did not have a stroke, which was great news. That is a really helpful frame for families to put those test results in context. As we look at our next swap, so this could easily be being said as a definition for families. Tommy has bronchiolitis. It's a lower respiratory tract infection caused by a virus, usually RSV. We're not seeing it this year, that can lead to focal areas of mucus plugging, which is the reason for his respiratory distress and frequent desaturations to the 80s. Deep suctioning may help. This is a sentence that I have said. I mean, I definitely have your spiels, right? You have your spiels. I know you guys, I'm thrilled to find out that you have the Center for Healthcare Excellence and Communication offered through the Department of Internal Medicine. I've taken much of that coursework, and it's a paradigm shifting frame. I really encourage you. And one of the things they taught me was people are more likely to remember a conversation than a speech. And we tend to have speeches for our spiels. Asthma is, cellulitis is, bronchiolitis is, leukemia is, right? We have our speeches lined up. Find a way to deal them into the conversation. Pull them in a conversation. What's your understanding about croup? Wasn't that the thing where X, Y, or Z? And then you can build off of that. If they go, gosh, I've never heard it before. Yeah, a lot of us haven't. Most people haven't. It's actually something that's really common. It's when and then you share, and you have almost a counter on your shoulder saying, don't say more than 3 or 4 sentences before you deal them back in. How's that sound? How's that resonating to you? Is that something you've heard of before? Finding a way to keep it a dialogue is way more beneficial in retention. And an analogy I remember from that course is that we tend to have a 2-gallon jug of knowledge about our topics. Think about it like our spiel of bronchiolitis is. We paid $146,000 to acquire that. This is very important to me. And I used to think I need to share all of it because I'm going to tell to families about the 4 or 5 reasons a patient stays in the hospital with bronchiolitis, what the new guidelines say. I'm just going to dump it all out. Yet the data show that families retain about 10% accurately of what we tell them. They have a shot glass compared to our 2-gallon jug. And I used to think, but if I pour slowly and I don't use jargon, that'll do it. That still is too much to retain, and really is just me showing off. If I really, examine sometimes, look how much I know, as opposed to what is it you really need to know. And so that assessing the shot glass, many families will put out more than 1 shot glass for you, but it's not our assumption that table's lined up ready for the 2-gallon transfer of knowledge. Can I just go home, says the patient. I know you want to go home today, but the reason you need to stay is that the treatment for pyelonephritis requires IV antibiotics until you defervesce, which means you become afebrile. Do you have any questions? Now, there's the obvious jargon in this phrase. I want to highlight 2 nuanced phrases. The first, but. We've been talking about jargon 101. This gets into graduate level skill. Remove the word but from your vocabulary. We tend to use but to negate the validation we are providing to the first half of a sentence. So somebody said, yeah, I hear what you're saying, but immediately takes away that we validate. I think you're doing a great job on this rotation, but one thing I want you to do differently is very different, right? It takes immediately the sting of that compliment away, versus removing the word but and putting a period there. I think you're doing an excellent job on this rotation. One thing I'd like to see you try tomorrow differently is very different. It lets the first clause stand. Gosh, I hear what you're saying. The reason I feel differently is very, I hear what you're saying, but. And so a patient saying, I want to go home. I know you want to go home, but you need to stay because I know you want to go home. The reason it's important to stay is because with this particular bacteria, right, I'm now sharing information that's not undoing it. This is really powerful tool. Replace the word but with and, or I know you want to go say, and the reason it's important to stay is. I actually prefer the period, but you'll see people use both. And then another thing I learned from the communication course is that any to what transition. When we say, do you have anything else? Do you have any questions? That is a yes, no question compared to what else do you want to talk about? What questions do you have? I expect them. Now, many times families will just say, nope, I think you answered it. Giving that expectation, it's actually been studied, providers shake their head no almost half the time when they ask the any word. Do you have any questions? We lead the witness versus what questions do you have? I want to say one thing about interpreter use here. I actually will use my time with interpreters to practice these skills even more. And so it goes from where I was providing substandard care, meaning similar care, meaning the type of communication I was doing was definitely different with an interpreter. I was kind of just quick, short sentences and not digging, to saying, well, let me use the interpreter to say, what's your understanding of bronchiolitis? What's been told to you about croup? Really use some of these best practices because I have this artificial pause to be able to get in my own head and practice. What do you want to make sure to talk about? So I've actually pivoted from them trying to, when I work with an interpreter, trying for those to be the best communication encounters I have, as opposed to close to my standard. I think it's worth examining ourselves there. Got one more example before we really pause for reflection and questions here. I'm sorry, but we have some bad news. I believe your baby has trisomy 21 or Down syndrome. We'll need to run some more tests to be sure, but given his facial features, decreased tone, and other physical findings, I'm afraid to say I'm quite certain it is Down syndrome. I'm sorry. These phrases are being said every single day to families with Down syndrome, with any kind of unexpected diagnosis. And what happened with me around this work was I met with a mother of a patient of a child with Down syndrome who wanted to talk about how to get providers communicating about this better. And she was telling me her story of her son. And if I could change one thing, it would be how I was told. It would be not trading the chromosome in. It would be how I was told. And I remember in this moment, she's like, it was broken as bad news, and it's not bad news. And I remember, if I examine my heart in that moment, I was not there yet. I remember thinking, oh, I didn't say this out loud. And I've since confessed this to this mom, but in this moment saying, oh, but it is bad news. I could see how you've adapted to that. And sure, like that was the frame I was in this moment. And the next patient I took care of was a child with Down syndrome. And I asked the family, could you tell me about the story about how you were told? Oh, please don't make me go back there. That was the part I would change. I went into Google. I went into Google and I saw all the things that could be wrong with my child. And I wish now I could hack back into that WebMD list and put on the top of the list would be the joy of your family, would cause your family to reflect on what's important in life, would make it so that their siblings were never bullies. Things that are actual, also proven benefits that aren't on that list. And it did get me to reflect on, gosh, we're doing so much important work about reflecting on our implicit biases and the way that our lived experiences shape how we interact with patients and everyone. And we often are viewing that through race, socioeconomic status, gender, sexual identity, etc. But I had not thought about it in the frame of a diagnosis, and that I do carry bias around certain diagnoses. And in fact, when I went back to this mom and we acted about how could we get better at this? Could we write a paper together to kind of put together a framework? One of the reviewers, who was a parent of a child with Down syndrome, said, I bet that doctors have a very special bias against diagnoses that have potential cognitive limitations, because by definition, they have prized the highest cognitive achievement possible of a doctorate degree. The same way an Olympic athlete may have a particular bias against limb deficiency, for example. And it really did reflect that, one, the place in which we see patients as a hospitalist feed that bias, as well as seeing only the sickest patients. I remember taking care of patients with bone marrow transplants as a resident, thinking I would never want anyone in my life to ever get a bone marrow transplant, not realizing I was taking care of the 10% in the hospital, not those that were doing well in the outpatient setting. So that really got us to reflect again about these stories from families and the data that show that over 94% of families of children with Down syndrome would not change the diagnosis if they could. Their biggest complaint was how providers and people have treated them about their child, or how the news was shared as objectively bad. And so as we sat with this mom and dad and started to come up with, well, what are ways to do this? We created a framework of reframing this breaking bad news bias. At first, recognizing our words will be a part of this family's story forever. You may have heard of the research on flashbulb memories. These are the memories that we all have a moment to get burned in our mind. And we have some collectivist society, the Twin Towers, O.J. Simpson's verdict. You know, it's funny. The most recent one I remember is obviously January 6th, but I remember Robin Williams, where I was when I found out Robin Williams had died. Those moments that etch in our mind, JFK assassination. What I didn't realize is the power we hold as providers is we hold the camera. We hold the flash. It is our opportunity to shape how that conversation goes forever. We should take that role very seriously. And that includes remembering to congratulate a newborn on a family on the birth of their child. Even if there's an unexpected diagnosis, what families will say is, nobody congratulated me. It was like a funeral procession. So add to your vocabulary, congratulations, what a beautiful baby, as you're adding this. And recognizing that the sentence, I have bad news, often is our bias, that it is objectively bad. When that's not the way it ultimately has come to be viewed, we should pause and reflect if we are sharing news as objectively bad when in fact it's just unexpected. And so in this paper, I'll make sure you have access to this as well. We lay out their story and kind of the strategies behind some of that language to consider. And this is not just true for Down syndrome, it's true for anything where an expectation might be altered from what the norm was. I'm sure people have heard the poem Welcome to Holland about a family who was expecting a trip to Rome. Their whole life they planned to go to Rome and they'd saved up for it. And they're in the airplane and the captain says, we have an unexpected diversion. We have to land in Amsterdam, or we have to land in Holland. And the family goes, I wanted to go to Rome. I was planning to go to Rome. I packed for Rome. My whole family thought we were going to Rome. Everybody on Facebook's talking about Rome all the time and how great Rome is. And they get off the plane and they go, okay, this is more beautiful than I expected. Oh my gosh, who knew how much I wanted to be in Holland? They may still mourn Rome. They embrace and love the journey in Holland. And that's a story that I think can be helpful for us as we frame these flashbulb memories for our families. And so one pivot, of course, there is objective bad news in medicine. I'm not trying to be Pollyanna. I'm causing us to reflect on how often if we really dig deep, that's our bias. And even after doing this work, I used to share a new type 1 diagnosis of diabetes as bad news. And I have been modified by that from residents saying, it's not bad news. I have type 1 diabetes. It's who I am. It's what made me become a doctor. And so, yes, it's unexpected. And there's plenty of positives we can talk about too. So I would not frame that as bad news. And that list has gotten smaller and smaller for me. I do want to highlight, I'm on the board of this organization as a non-paid medical advisor. But if you ever have a patient that has been diagnosed with Down syndrome, you can go to Jack's Basket. This mom and dad started this nonprofit, and request a basket to be delivered to congratulate the family, paired with local resources to the institution. We have this we delivered probably 40 or 50 baskets in San Francisco, when possible, it's delivered by a family of a child with Down syndrome, so that there's that connection as well. So you can check out that. I want to end with a video. I'm going to tell you, if you're homeschooling and you have kids near you, there are a couple moments with some foul language here. So take that with a grain of salt, incorporate your volume if need be, and then we'll reconvene on the other side.
You can say almost anything.
Like, holy shit.
You just had a baby.
Shit, yeah.
Congratulations.
恭喜恭喜.
She's so cute, I want to barf.
Well, there goes your sex life.
You just squeezed out a human.
Does your vagina hurt?
I hope you are ready for lots of shitty diapers.
Yay!
Behold, the miracle of fucking life.
See, you can say almost anything.
The truth is, the only bad word is sorry.
Sorry.
You're supposed to be celebrating.
Woohoo! So don't be sorry about a baby.
Be happy.
Because every baby deserves a warm fucking welcome.
You know, I hope you've enjoyed our time together. I know I get excited talking about this work, and I just want to recap what we talked about. We talked about what jargon is, why it's a problem. We looked at the categorization scheme for jargon so we could systematically audit ourselves and our colleagues and give each other feedback about how to remove things from our vocabulary. And then we practiced some simple swaps of how even single words, when and where we say sorry, but, what, any, how single words can change the meaning of things for families. And I hope that you'll start incorporating some of this work. And I really can't encourage enough you to take the communication course that's offered by your Center for Healthcare Communication. It certainly changed the way I practice. So with that, I will look for questions in the chat. I really appreciate you inviting me.
Thank you so much for this really fun and also just, I think, very educational talk, and highlighting so many of the things that are so ingrained in what we do, and we definitely can do better. There are a few questions on the chat. Before I get to that, let me just reiterate, and we will send the link out with the link to the recording and the evaluation of this talk. But the UCSF Center for Relationship Centered Communication gives an outstanding course currently over Zoom. It's a one-day workshop on relationship-centered communication, and it gives you the opportunity to apply this and skills as part of your, I'm sure all of us have decided that this is what we want to practice from here on. Less jargon, more clarity, and more kindness, I think, too, is part of the message here. Dr. Pitt, so one of the questions here is, thank you, Dr. Pitt. It seems there would be so much more clarity even in our conversations with one another if we would cut out jargon and speak plainly. Even across specialties, we throw around words not really understanding what they mean to one another. It's not really a question, but it's I guess a request for you to comment on that.
Yeah, I mean, I really couldn't agree more. I occasionally get pushback around kind of the need to be precise. And I'll have somebody say, well, I want a learner to say to me that the pharynx is erythematous and the right tonsil has an exudate. And my concern is the more we have to toggle, the more that's when we forget that we're using jargon with families. And so I would prefer that we certainly need to be able to recognize the terminology, but I really encourage my trainees to do that in plain English, even when talking to a consultant. You know, there's a moment where there's that precision that needs to be shown. I think that certainly when you're describing a location, but I couldn't agree more. I will reflect on a really interesting conversation with a colleague recently who talked about her role as an immigrant physician and who trained in Nigeria, and how she felt if she didn't use jargon, she wasn't taken as seriously as other colleagues. And I never had really reflected on the role privilege can play in the privilege to be able to speak plainly and conversation. I think that is something that absolutely is worthy of a discussion, so that it may not be one size fits all kind of in a prescription. I certainly think I'm across colleagues, and we just need to be safer to say, yeah, I'm sorry, I don't, you said MRCP, remind me what that is. We need to be safer to do that among our colleagues for sure. There's a question here about the word observe or monitor. And I wonder if it has to do with kind of like if you're monitoring, like you're following labs or you're following something and, over time. And I think if you're asking the question, it means that you've thought maybe this is something that's led to confusion. I think that that's not one that I would have thought of, but I catch things all the time that I go, actually just talking with my mother-in-law who's got ovarian cancer and going through monitoring CEA levels or CA 125 levels. The passivity of monitoring has caused some anxiety, right? Aren't you going to do something? We're just going to sit here and watch this number go up, as opposed to kind of, so maybe that's what we're getting at. And certainly that's, again, we're empowering people with those emotions behind decisions, I think can really help them frame things.
Yeah, and if I may sort of add to that prior piece about the language that we're using, I think you actually brought this up, but there is, of course, a there are some utilities to certain terminologies that we use, right? I personally, as an intensivist, it drives me crazy if a trainee speaks about ARDS as inflammation of the lungs, because ARDS actually has a very specific definition for very clear purposes. But I liked how in some of your examples you said, well, it's a term we use to define X, Y, and Z, right?
And,
So
and what I've done for some of my things in the open notes era is if I have a dot phrase, for example, for, you know, the insurance company makes me say acute hypoxic respiratory failure secondary to bronchiolitis caused by RSV, right? So if I have a dot phrase for that, I've now added a parentheses after it that has a plain language explanation of that, knowing families may need to see it, maybe seeing it. So that's something you can kind of audit your dot phrases and say, could I capture something that could be summarized to families for sure? And I think, I echoing your point, gosh, when you try to get jargonless in your description of ARDS to a family, sometimes you do have to swing to the most similar thing they could understand, which may be inflammation, even if it's not as technically correct. So it is a challenge for sure. Yeah, you know, this suggestion around informed consent. So this is where the communication course, if it's the same one, we'll teach you a frame called ARIA, which is, it's similar to kind of ask, tell, ask, but it's assess, reflect, inform, assess. And it's a way to get into that dialogue. So for informed consent, instead of the spiel, if it turns into a conversation, again, today, your doctor, you know, we need to do this procedure. What's your understanding of why we need you to do the procedure? Assess, reflect. Yeah, exactly. Inform. This is what we're going to do from here. What might you anticipate some of the common risks are of that procedure? If they can generate it rather than me telling them. So on a discharge day, rather than me telling somebody with a rat cellulitis, these are the 4 things you need to come back for. I might say to them, what are the things you think we want to make sure you come back for? You know, it's helpful if I hear you generate those rather than me just throwing them. We can fill in any gaps. So that can happen in informed consent. What are the risks that you might see? Yeah, let me add a couple more. What are the reasons you think we're doing this? How do you think it may help? And if they have an unrealistic benefit, it's important to hear that from them. So absolutely.
I think that covers all the questions in the chat, and we are almost at time. Glenn, any concluding comments? Oh, wait, I have one more question here. Do you find differences in jargon use between inpatient and outpatient patient clinicians?
Yes. So whatever your wheelhouse is where you're going to start developing jargon for terms that you forget you didn't understand. So whatever your specialty is, you're going to have them. And it has been studied. Again, in our study, we found 4 jargon words per encounter. And in the best outpatient study, there are very few actual in the wild studies. They're mostly simulated. But in the one that was a recorded patient encounter with permission, it was also 4 times per encounter. So whatever you're saying a lot of, that's where you're going to be set up for forgetting that you know something. And to this, preparing trainees for family-centered care, what you heard me talk about when I said, this is what a SOAP note looks like, take the middleman out, that Jack's rash is no longer erythematous tender desquamine example, that is part of my orientation to a week of service. So I'm coming on service. What I start with the question, what is the purpose of rounds? And I have everybody say what they think the purpose of rounds is and one thing they'd like feedback on over the course of the week. And so as we go around the circle, and then I'll share what I think the purpose is of rounds and use that as a frame to talk about and what I want feedback on for the week. And then use that as a frame to talk about family-centered care. So it cannot just happen accidentally. It does need prompting for sure.
Thank you so much. I think we're at the top of the hour, so I am going to let Dr. Hirsch wrap it up for us, if that's okay.
Well, thank you, Dr. Pitt. That was really fantastic and a lot of good lessons for all of us to take away from this session. I was hoping you were going to explain how to do that card trick without the jargon, because I didn't get it, but I'd love to know how to do that trick. So maybe you can, maybe at some point we can get the simple explanation for how to do that. But thank you so much. We've really enjoyed this presentation.
Thanks for having me. Bye, everyone.